Welcome everybody to our OVATION rounds. As you know, OVATION rounds is a program that we have initiated over the last 3 years with our sister institution, Vancouver and UBC. We've had many exemplary speakers give talks which were well received. And today I have the privilege and honor of introducing to you Dr. Jason Andrade. I'm sure many of you know of him already. Dr. Andrade is a cardiac electrophysiologist at Vancouver General Hospital, and he also has joint appointment at the Montreal Heart Institute. He's an associate professor at UBC and an assistant professor at Université de Montréal. Dr. Andrade is currently the director of electrophysiology and director of the Atrial Fibrillation Clinic at Vancouver General Hospital. He's also co-chair of the Canadian Cardiovascular Society Atrial Fibrillation Guidelines Committee and chair of the Canadian Heart Rhythm Society Device Committee. In addition, he is the medical chair for heart rhythm diseases for the Cardiovascular Disease Network in the province of British Columbia. Dr. Andrade is a prolific clinical trialist and author who has already published over 200 scientific peer-reviewed publications, predominantly focusing on atrial fibrillation. He has published in NEJM, Circulation, JACC, and JAMA, just to mention a few of the high impact journals. He's also authored many textbook chapters and is quite tech savvy with medical apps to his name, and has a great profile on Twitter in case you follow him there. So with that introduction, I would like to thank Jason for taking time from his busy schedule and being 3 hours behind us to have come on at 5 a.m. today and then at noon. Thank you, Jason, and let's go ahead.
No problem. Thank you very much for the introduction. And I apologize if there's a puppy in the background chirping away. She's a little young addition to our home. So it's my pleasure to speak with you all. Obviously, it would have been much nicer if I were able to visit. Girish didn't mention I did my medical school actually in Ottawa before coming out to BC. So Ottawa has a near and dear kind of fondness in my heart. So I'm quite sad that I can't be there with you today. So today we'll speak about the evidence supporting early ablation for atrial fibrillation, and I'm going to highlight a couple of trials that we've done and some of the evidence underlying that that we've generated over the past few years. Here are my disclosures. And so being Canadian, I thought we'd start with a case presentation of someone who we may all know. So this is a 40-year-old gentleman who developed paroxysmal atrial fibrillation. And this was limiting for him. He had effort intolerance. He couldn't perform to the best of his abilities, had a baseline history of hypertension, has an echo that's entirely normal, as was his physical examination. So if we look to the guidelines in Canada, the US, and Europe, there's a preference to proceeding with antiarrhythmic drug therapy before considering an ablation procedure. And largely this is around the perception that antiarrhythmic drugs are more benign, invasive procedures have risks, and we wouldn't want to proceed with anything that would be harmful for the patient without a good reason to do so. But the problem is that those assumptions aren't necessarily correct. Now, we have had multiple randomized controls trials done comparing antiarrhythmic drugs to placebo. So there is randomized blinded evidence. And we know that antiarrhythmic drugs, and I'm showing you 5 here on this slide, which is a network meta-analysis. The antiarrhythmic drugs are all more successful than placebo at preventing arrhythmia recurrence with hazard ratios of 0.3 to 0.5. So the drugs are effective at preventing atrial fibrillation from coming back in relative terms, but in absolute terms, they're still relatively ineffective. So this is from our early AF study, which I'll highlight a little bit later, but looking only at the antiarrhythmic drug arm, you see about less than a third actually of patients who are free of recurrent atrial fibrillation despite aggressively titrated antiarrhythmic drugs using standardized protocols. So even in the best case use scenario, antiarrhythmic drugs are not entirely able to eliminate atrial fibrillation. The flip side, though, is that if we give these drugs, they're also poorly tolerated. So again, returning to the network meta-analysis, we see that the discontinuation rates of antiarrhythmic drugs is significantly higher than placebo by about, a doubling in the rates of discontinuation. But more concerning than that is actually the risk of all-cause mortality. So this is a sub-analysis that was done looking at the Affirm study. So Affirm was the landmark rate versus rhythm control study published by George Wise and colleagues. And you can see here on the left side that being in sinus rhythm was associated with a significant reduction in all-cause mortality. So being in sinus as opposed to AF was associated with mortality benefit. But as you see on the slide, if you needed an antiarrhythmic drug to get there, it was associated with a 50% increase in mortality. And so if you think about Affirm as being a trial of sort of being negative in terms of the benefits of rhythm control, it may be that the benefit of rhythm control was actually negated by the antiarrhythmic drugs that had to be used to get you there. And this is not necessarily a spurious observation. And so in the early AF study, again, which I'll highlight a little bit more later, we've implanted loop recorders in every patient. So we had continuous cardiac rhythm monitoring in the ablation group, as well as the antiarrhythmic drug group. And you can see that malignant arrhythmias, such as the polymorphic VT that you see on the left side in the sotalol-treated patient, as well as the monomorphic VT in the flecainide-treated patient on the bottom right side, these are pro-arrhythmia events secondary to the use of antiarrhythmic drugs. And so the antiarrhythmic drugs do result in increased propensity towards arrhythmia. If we go back to that network meta-analysis that I showed you earlier, you can see that all-cause mortality was almost tripled if patients were treated with amiodarone relative to placebo. And if sotalol was used, the mortality was more than 4 times higher. And so the use of antiarrhythmic drugs is associated with higher mortality in placebo-controlled trials, as well as in observational analysis of randomized trials. Now, the flip side of that is, what about ablation? So we know that ablation is universally more effective than antiarrhythmic drugs when antiarrhythmic drugs have failed. And so all of these are randomized studies comparing drugs to ablation. And you see that ablation is much more effective than drugs at preventing arrhythmia recurrence. Now, we can't extrapolate this evidence to first-line ablation because first-line ablation implies that patients have not failed a drug. These studies are done in patients who failed a drug and therefore are biased towards the ablation being the better outcome. And if we look at quality of life improvement comparing drugs to ablation, you can see across several trials that the difference between the treatment groups is significantly in favor of ablation. So catheter ablation increases the quality of life score beyond the clinically meaningful threshold of 5 points. So you get a better quality of life improvement with ablation relative to drugs. And then we also know that catheter ablation is more effective when we perform it early. So you may recognize this slide from the 2020 CCS AF guidelines. And what it's demonstrating is a representation of the life cycle of atrial fibrillation. So early in atrial fibrillation, in this light blue wedge, the arrhythmia is driven by triggers. So it's an isolated electrical problem, predominantly originating from the pulmonary veins. As time goes by, so moving to the right on the x-axis, you see that the relative balance of trigger-based arrhythmia to substrate-based arrhythmia changes. And so as AF episodes occur, they lead to structural and electrical remodeling in the heart. That structural and electrical remodeling results in increased propensity towards AFib. And so you can imagine that if I do an ablation procedure earlier, focusing on isolating the veins, it's more likely to work than if I do the same procedure later, where there's actually abnormalities in atrial myopathy that drives the AF. And this is what is indirectly observed. So here you have 2 survival curves for arrhythmia freedom for a cryoballoon-based pulmonary vein isolation procedure. In blue is the same procedure performed in paroxysmal patients. In red is the same procedure performed in persistent patients. And you can see that the outcome in blue is much better when you perform pulmonary vein isolation in patients early in their disease course relative to patients who have more advanced forms of atrial fibrillation. We've done an analysis of our Circuitos study where we've looked at AF episode duration prior to ablation and correlated that to ablation outcomes. And so what we did was use the loop recorder data that was recorded in the months prior to the AF ablation procedure. We classified patients by their longest AF episode duration, and then looked at their outcomes following ablation. So everyone had their ablation as they would within the study protocol. And you can see that patients whose AF episode durations were less than 24 hours had a significantly greater freedom from recurrent arrhythmia compared to patients who had longer durations. So if the episode lasted 36 hours, effectively their freedom from recurrent AF was no different than if they were a persistent patient who was in continuous AF for longer than a week. And so the idea that maybe we should intervene at a time before the AF episodes are prolonged might improve long-term outcomes. By extension, people have looked at this from the idea of delaying the ablation procedures. So looking at time from diagnosis to when the ablation is performed. And you could see that with increasing quartiles of time from AF diagnosis, the success of ablation decreases. But probably more relevant to the cardiology community is that you see more strokes and TIAs the longer you wait to perform the ablation procedure, as well as more heart failure admissions, recognizing that the most common cause of death in AF patients is actually heart failure. And so outcomes that are significant and concerning to us as clinicians are worsened the longer we wait to perform an ablation procedure. Lastly is the concept that maybe performing ablation early will change the disease trajectory. Again, I highlighted this a moment ago, that early in the disease, AF is a predominantly electrical problem, but this orange wedge represents AF-induced electrical and structural remodeling, meaning that the AF itself drives the disease progression from paroxysmal to persistent AFib. And so maybe if we target the substrate or the reason why they're having atrial fibrillation early, we can prevent that progression from paroxysmal to persistent AFib. And this is analysis done out of McGill, where they looked across multiple studies. The studies compared medical therapy, so 21 studies of about 13,000 patients, to catheter ablation, which was 8 studies of just under 3,000 patients. And you can see that in blue, using medical therapy to treat the atrial fibrillation, so antiarrhythmic drugs, there's no change. There's just a steady progression from paroxysmal to persistent AFib, such that at 10 years, about 40 to 50% of paroxysmal patients are now in persistent AFib. But interestingly, if you look at the ablation group, by targeting the reason they have atrial fibrillation, you actually seem to halt the progression of disease, meaning that you can keep patients paroxysmal rather than persistent. This is important because we know that persistent AFib is associated with higher rates of heart failure, higher rates of stroke, and higher rates of adverse outcomes when we compare that to paroxysmal patients who have a lower burden of arrhythmia. And so with that sort of preface, the question sort of arises as to whether or not the guideline recommendation of antiarrhythmic drugs before ablation should be flipped. So maybe ablation is the better approach. We should start with that. And those that fail ablation, well, those are the ones that we should supplement with antiarrhythmic drugs. Now, prior to this past year, there had been a few randomized studies looking at this. So the RAFT pilot, which was 70 patients, MANTRA-PAF, which was about 290 patients, and then RAFT-2, which was about 120 patients. And so these studies were looking at antiarrhythmic drugs versus radiofrequency ablation as a first-line procedure. In the case of MANTRA-PAF, it was a bit of an outdated procedure, something called a LACA, which for the electrophysiologists will recognize what that is, but for non-electrophysiologists, it's just to say it's not what we would consider to be a contemporary AF ablation procedure. The studies were all collectively fairly small. There were very high rates of crossover. So patients moving from the antiarrhythmic drug to the ablation group. In the case of the RAFT study, the endpoints weren't blinded. So there's a question of whether or not bias was introduced. And on the whole, the results were not really compelling. And so if you look at any atrial tachyarrhythmia recurrence, you see that the MANTRA-PAF study was actually negative at preventing recurrence. If you combine that with RAFT-2, there was a slight reduction by about 20% with ablation. If you look at symptomatic arrhythmias, the 2 blinded studies were negative. The unblinded study was strongly positive. And so there's a bit of heterogeneity there that makes it hard to put these studies together. And because of these results, as well as the limitations I addressed on the last slide, the guidelines did not recommend a change in practice, or did not recommend that we should proceed with catheter ablation as a first-line therapy. So because of that, we initiated the Early AF study. And so the Early AF study was a CanNet-funded study with support from Medtronic, who makes the cryoballoon catheter. It was a large Canadian collaboration. So essentially we had centers involved coast to coast. There were 18 centers who participated from Victoria to Halifax. The investigators I've listed there. It was coordinated through Ottawa with Patricia as our project manager and George Wells as our chief statistician. And it was really, as I say, a coast-to-coast success story for the Canadian EP community. And so what the Early AF study was a randomized study looking to see if first-line cryoballoon ablation could be superior to antiarrhythmic drugs, with the caveat that we implanted loop recorders in all these patients. So we wanted to have a definitive answer. We wanted to know with absolute certainty whether ablation was better than drugs at preventing arrhythmia recurrence. And so our primary endpoint was the standard endpoint that the guidelines recommend that we should use, which is 30 seconds of AFib after a 90-day blanking period. We included secondary endpoints that are more relevant to patients, so symptomatic arrhythmia. We also looked at arrhythmia burden, or the amount of time someone is in AFib, which is probably where the outcomes of studies is going. We wanted to be comprehensive in our design, so we looked at quality of life using disease-specific and generic metrics, as well as symptom scores. And we also wanted to see if there was any impact on healthcare utilization, so emergency room visits, hospitalizations, cardioversions. And so we wanted to have the most comprehensive, most sort of definitive evaluation. So the Early AF study is the largest first-line ablation study performed. We had 303 patients with treatment-naive symptomatic AFib, about 150 patients randomized to each group. All of them had a Reveal Link loop recorder implanted, and then they were followed for a year with clinical encounters and quality of life assessments, as I mentioned. The baseline characteristics for the patients in the study is fairly consistent with what we would expect for a first-line study. So generally healthy. It's going to be younger patients, mostly men. The comorbidities that were most common were hypertension, sleep apnea, and obesity, which are mostly what we would see in this, relatively healthy cohort. The important thing to keep in mind is that at the time of enrollment, these patients were highly symptomatic. So they were about a year from their diagnosis. They were describing 3 symptomatic episodes per month. About 40% had previously had a cardioversion, and objectively, their quality of life score was severely impaired. And so these are not patients with a first diagnosis of AFib. These are not asymptomatic patients. These were patients who had not been treated, but were significant enough in their symptomatology to warrant an intervention, whether that's pharmacotherapy or an ablation procedure. For the antiarrhythmic drug group, we used standardized protocols. So we did not want to be accused of under-treating our control group. So we created protocols that were provided to the sites that dictated how the drugs should be titrated. And we asked the sites to review the loop recorder data every week. And if atrial fibrillation was seen, we wanted patients to have their drugs adjusted. And if the drug failed, change to a second drug. And so you can see that 30% of patients needed 2 different antiarrhythmic drugs during their 90-day treatment optimization period. About 5% ended up going on to a third-line drug. Amiodarone use was low, but consistent with it being a second or third-line therapy. The doses of antiarrhythmic drugs that we had in our study were therapeutic across the board, and they were reasonable doses. So it's not like we undertreated part of our study. In terms of the ablation procedure, we used 3-minute freezes. We did include bonus freezes for the electrophysiologist in the audience. The procedure duration, including a waiting period, was 106 minutes. The left atrial time, including a 20-minute waiting period, was 73 minutes. So if you cut that out, you could say it's less than an hour in the left atrium. Ablation duration, 26 minutes, and mostly done with the big cryo balloon. And here's our primary outcome. So our primary outcome was freedom from any atrial tachyarrhythmia on the loop recorder. So remembering that the loop recorder records all arrhythmia events. And what we saw was a 29% absolute difference between the ablation and antiarrhythmic drug group. So you could convert this into a number needed to treat of 4 patients to prevent 1 recurrence of atrial fibrillation, flutter, or atrial tachycardia on follow-up. And that was about a 50% reduction with ablation relative to antiarrhythmic drugs. In terms of symptomatic arrhythmia, so this is the more relevant outcome and the one that's not as influenced by the fact that you had continuous monitoring in all patients. And you can still see that there was an absolute reduction of 15%. And now you're looking at about a 60% relative reduction. This translates out to a number needed to treat of about 7 patients to prevent a symptomatic recurrence. Again, both of these outcomes were highly significant in favor of ablation being preferred to antiarrhythmic drugs. When you look at the burden of atrial fibrillation, or the percent time that patients were in atrial fibrillation, the difference between groups was 3.3%. 3.3% may sound like a low number just because it's small, but if you put that over a month, 3.3% is 1 day less atrial fibrillation per month for patients treated with ablation relative to antiarrhythmic drugs. And so for a patient with paroxysmal atrial fibrillation, if you can give them 1 less day in atrial fibrillation per month, that's a substantial reduction. This slide's not meant to be sort of poured over, but it's just to point out that for every single way that we analyzed arrhythmia outcomes, whether it was any arrhythmia or symptomatic arrhythmia, whether it was confined to atrial fibrillation or broader atrial fibrillation, atrial flutter, atrial tachycardia, it didn't really matter what outcome you looked at. In each case, the ablation group had significantly better outcomes relative to antiarrhythmic drugs. And I mentioned that a 3.3% reduction in burden, if you multiply that out by a month, is basically 1 day less AFib per month. If you look at the last line, you see that the difference in the amount of days with atrial fibrillation was 3 versus 16 over the year, which is very consistent with that outcome. In terms of quality of life, a similar pattern exists. So the first takeaway is that untreated atrial fibrillation gets better if you treat it. So there was improvement in quality of life with antiarrhythmic drugs as well as with ablation. However, the magnitude of improvement was significantly better with ablation relative to drugs. And it was significantly better to a degree that was clinically meaningful, meaning that the effect score that we saw that improved exceeded the clinically important difference, which is 5 points. So we saw differences of 8 to 10 points. For the generic quality of life score, so the EQ5D, a clinically important difference is 0.03 points. And so we saw that or double that, depending on the time of follow-up. Patients treated with ablation were much more likely to be asymptomatic at both 6 and 12 months. Now, the flip side of saying, well, maybe we should do an intervention as the first therapy for atrial fibrillation is whether or not we're providing or we're exposing patients to harm. I can happily say that there did not seem to be any difference in adverse events between these groups. So if you look at the serious adverse events, there were 5 in the ablation group and 6 in the antiarrhythmic drug group, again, adjudicated by a blinded committee. For the ablation group and the antiarrhythmic drug group, there were 2 patients in each group who had bradycardia and needed a pacemaker. In the ablation group, the only complication of the procedure was 3 phrenic nerve injuries that resolved at 1 day, 1 week, and 1 month. So transient phrenic nerve palsy related to the cryoballoon. For the antiarrhythmic drug group, I've already shown you these 2 tachyarrhythmia events. So the polymorphic arrhythmia in the sotalol treated patient and the monomorphic arrhythmia treated in the flecainide treated patient. There was 1 heart failure exacerbation in a flecainide diltiazem treated patient. And there was 1 syncopal episode that occurred in the context of a myocardial infarction in a patient who was receiving flecainide. And that was actually due to proarrhythmia as well when we looked at the loop recorder tracings. So highlighting that the antiarrhythmic drugs are not necessarily benign in terms of serious events. If you take the broader definition of any safety endpoint, so this is just including anything at all, there were 14 patients in the ablation group and 24 patients in the antiarrhythmic drug group who had some safety event, 15 events with ablation, 27 versus antiarrhythmic drugs. There was no significant difference statistically between groups. Most of the drug side effects were, most of the adverse events in the drug arm were side effects like presyncope, tremor, visual disturbance, but the serious ones I've highlighted for you. So from the early AF study, we can conclude that ablation as a first-line therapy was associated with improvements in basically every arrhythmia outcome. And that improvement in arrhythmia outcome translated into meaningful improvements in quality of life and symptom status. And it did not seem to come at a cost of increased adverse events. So following the publication of early AF last year, it was presented at the AHA meeting and then published online same day. We initiated a collaboration with the Stop AF First group, which is a US-based study, and the Cryo First group, which is a European study. And so the reason we were able to collaborate with these three groups is effectively three separate studies looking at antiarrhythmic drugs versus cryoballoon ablation as a first therapy. And so it allowed us to put our 303 patients together with another 420 patients and get much more power to look at the adverse cardiovascular outcomes. And so when we look at these three studies, you see very consistent results in terms of improvement from arrhythmia recurrence. And so I'm showing you the three Kaplan-Meier curves, showing you the freedom from recurrent AF in the ablation group versus the antiarrhythmic drug group. And then at the bottom, I'm showing you the crossover rates. So the key thing with early AF is we had a committee that prevented crossovers. So no patient crossed over between treatment groups as well, because we had protocolized antiarrhythmic drugs. We also didn't see any subtherapeutic antiarrhythmic drug therapy. However, if you look at the other studies, about 15 to 20% of patients in Stop AF either crossed over or were undertreated for their antiarrhythmic drugs, and then 7 and 14% in Cryo First. Now, if we return back to the Kaplan-Meier curves, while each study shows you significant benefit to ablation, if you compare early AF to Cryo First on the end, you may say, well, visually, these look very different, right? So in the Cryo First group, antiarrhythmic drug group in Cryo First, their freedom from recurrent AF was 70% almost. Whereas if I look at the ablation group in early AF, our freedom from recurrent AF was less than 60%. So this seems substantially different. And you might postulate that maybe Cryo First was just better at treating their patients, or maybe they had different types of patients enrolled. The key thing here to realize is it's solely a function of monitoring. So early AF uses loop recorders. Effectively, we will detect every recurrence. Cryo First used 7-day Holters, which means that at best, they had about a 60 to 70% sensitivity of detecting recurrences. Stop AF First used 24-hour Holters and TTMs, which gave them about a 50% sensitivity for detecting recurrences. So the issue here is that the apparent differences in survival, like Kaplan-Meier curve, are entirely apparent. There's no difference in terms of their success. It's solely down to monitoring. And so I showed this morning to Girish, but this is an analysis we published in Circulation from our Circuitos data. And what we showed is that in the blue line is the freedom from recurrent AF by loop recorder. And so in Circuitos, that was 52%. But if I had not used loop recorders in this study and instead used a 7-day Holter 3 times over the year, my success would have been 80%. And if I used a 24-hour Holter, basically what was used in Stop AF First, my success would have been 93%. So the same patients, same outcome, the differences are entirely down to monitoring. And I think this is a sort of a concept that we have to reconcile as an electrophysiology community, because between trial differences may not actually look like, or may not actually be differences. It may be just a function of how we look for AF recurrences. And so in this analysis, so that if we go back to the JACC meta-analysis that we published, you can see that in relative terms, because within each study, the monitoring was consistent, you see very similar outcomes. So it's a remarkably consistent reduction. So the risk ratio of 0.6 in terms of cryoballoon. So despite the Kaplan-Meier curves defining absolute success very differently, the relative benefit of ablation is very consistent between these studies. If we look at symptomatic recurrences, again, comparing early AF to Cryo First, very similar in terms of the outcomes with hazard ratios of about 0.4. If we look at adverse events, none of these studies documented a higher rate of adverse events in the ablation group relative to the antiarrhythmic drug group. So again, there does not seem to be harm to an invasive procedure. If you look at quality of life, very similar outcome in terms of the quality of life improvement that favors ablation over antiarrhythmic drugs. So again, patients get more better with ablation relative to drug therapy. And then lastly is the question around healthcare utilization. So if we consider the costs of AFib to the healthcare system, doing an ablation procedure is a costly endeavor. And so arguably, if we're going to pursue something that's going to take the upfront cost of an invasive procedure, we want to know that there's going to be some cost savings that come down the road. And overall, when you combine these 720 patients, ablation was associated with a significant reduction in healthcare utilization by about 30%. And most of that was actually driven by recurrent hospitalization. So patients are less likely to come back to the emergency room. They're less likely to get admitted. They're less likely to get cardioverted. And so when you think about how the costs of AF affect the healthcare system, in Canada, AF accounts for about $1 billion a year in healthcare costs. If you look across European jurisdictions, AF is about 2.5% of healthcare spending, and more than half of that is driven by acute care costs. So if we can reduce acute care costs by 50%, say, we will see a significant cost savings to the healthcare system. And I think that that's an important message as we consider moving some of these patients towards a first-line approach. So, if we put all these together, what we see is significant reductions in AF recurrence, significantly better quality of life, reduced healthcare utilization and hospitalization, but no significant harm provided to the patients with a first-line approach. And so I'll just, over this last little bit, address a couple of questions that have come up since we published these studies. So, these 3 studies are all cryoballoon studies. So we're talking about a single technological solution. Cryoballoon is a newer kid on the block in terms of ablation. I mean, that being said, 1 million cryoballoon procedures have been performed worldwide since it was released a little more than 10 years ago. So it's not like it's that new, but relative to point-by-point RF, it is the newer technology. And so people always ask, would I expect the same results if we used radio frequency ablation relative to cryoballoon ablation? And so then I turned back to our own literature. So the Circuitos study was a study we published a couple of years ago now. And this was a randomized study performed in Canada. This was funded by the Heart and Stroke Foundation. It took place at 8 centers, again, coast to coast, Victoria to Halifax, but not as broad as what we included for early AF. And what we did in this study was randomize patients to contact force radiofrequency ablation versus what we called the advanced generation cryoballoon. Within the cryoballoon arm, we compared 2 versus 4 minute freezes, which was some animal work that I had done 10 years ago. And we showed in the animals, at least, that those timings were equivalent. And so we were trying to see if that translated out into the clinical realm. And so for Circuitos, we enrolled 350 patients. We randomized about 115 to contact force radiofrequency, to cryo 4 and cryo 2. For the contact force arm, one of the important things for the electrophysiologist is we pre-specified the parameters. This hadn't been done previously. So we had a power criteria, we had a contact force criteria, and we used FTI, which is a measure of time and contact force. This has been supplanted by LSI, or the ablation index, but those things emerged after we had done the Circuitos study. Again, we used loop recorders in the study because we were comparing technologies and we wanted to be absolutely certain that we weren't introducing a type 2 error. And so we didn't want to have variability in arrhythmia detection be the reason why we may or may not see a difference. So everyone got a loop recorder. And what we saw in Circuitos is that cryoballoon procedures were shorter. So there's significantly lower procedure duration, significantly less left atrial time. However, that came at the cost of increased fluoroscopy. And so the interesting thing you see here is that I showed you our procedure times for early AF was 76 minutes. Here, our procedure times were a little over 100 minutes. So even in the couple of years between these two studies being done, we've seen the procedure times come down significantly. Now, in terms of the fluoroscopy exposure, it was significantly higher in the cryo balloon groups, which is a necessity of the cryo balloon based procedures. But the interesting thing is if you look at previous comparative studies of non-contact force radiofrequency versus cryo, our fluoro times in our cryo group were actually less than the fluoro times seen in the radiofrequency groups. So we even had lower fluoro times in our study compared to the previous literature, but our radiofrequency ablators were so good at getting their fluoro time down. There was only 5 minutes of fluoro used in that group compared to other studies where you'd see 20 to 30 minutes of fluoro. So it just tells you, how good our participating centers were in terms of their ablation experience. Now, in terms of the outcomes, there was no difference at all between these groups, but a 52% success for freedom from any arrhythmia. In terms of freedom from symptomatic arrhythmia, we had about an 80% success. So very comparable outcomes in terms of any or symptomatic arrhythmia recurrence. And the AF burden reduction was about 99%. So even though half of the group had an AF episode that lasted 30 seconds, because we were using loop recorders, we saw all of those episodes. And so they were blindly adjudicated and came back positive. But within the patient, if you looked at how much time they were in AF before the ablation and compared them to how much time they were in AF after the ablation, you saw a 99% reduction. And so, this loop recorder tracing is showing you that before ablation, these blue bars show up to 24 hours a day of Afib. They go on to have their ablation in early April. There's a little sputter of Afib in that early healing phase, and then nothing until this little break in the line. And so while this person in a randomized trial is a treatment failure, I don't think anyone would look at this patient and say that a 99.9% reduction in their AF burden is a clinical failure. And so this is a bit of a disconnect in terms of how we objectively assess ablation outcomes in randomized studies compared to what it means to assess it as a clinical perspective. Again, we've looked at quality of life outcomes in Circuitos, and to start, all patients had a severely impaired quality of life score by effect, and all patients saw a significant improvement, or all groups saw a significant improvement, and the improvement was about 30 points difference between them. We've subsequently gone on and done an analysis that correlates AF burden, or the percent time in atrial fibrillation, to the improvement in quality of life score. And this was published in JAMA Cardiology just a couple of months ago. And what we showed is that for every 10% change in atrial fibrillation burden, there was about a 6 to 10% improvement in their effect score. So I highlighted when I was showing you the early AF data that a 5-point difference is considered clinically meaningful. So arguably, if you can reduce their AF burden by 10%, you can achieve a clinically meaningful improvement for that patient. And this is one of the first studies that have correlated burden to ablation or quality of life outcomes, especially using loop recorder data. Circuitos also showed us that healthcare utilization was significantly improved following ablation. So if you took the year leading up to ablation and compared it to the year after ablation, the percentage of patients requiring cardioversion significantly decreases. The emergency room visits per patient significantly decrease, and the percentage of patients who require hospitalization significantly decrease. So the year following ablation is associated with substantial reductions in healthcare utilization. And importantly, in the table, it shows you that it doesn't matter if it's the proportion of patients who need that, the number of events that occurred, or the number of events that occurred per patient. So no matter how you measure it, the year following ablation is better than the year before ablation, suggesting that there can be savings in terms of healthcare costs pre and post ablation. So Circuitos would argue that the first line ablation results should extrapolate out to contact force radiofrequency ablation, because in Circuitos, the freedom from recurrent AF was similar, the quality of life was similar, and the healthcare utilization was similar. But importantly, we've gone back and reanalyzed some of the data in Circuitos, and you see this kind of spread. So in a low volume center, cryo performs better than contact force. In a high volume center, contact force seems to perform better than cryo, which kind of makes sense because contact force is much more dependent on operator experience relative to cryo. But you can take this even further. So here we broke down all of the centers in the study, and you can see that the cryoballoon ablation outcomes are clustered very closely together for all the centers. So whether you're a low volume center or a high volume center, the cryoballoon patients all achieved a similar outcome. Whereas if you look at the contact force, it's all over the map. Some centers are exceptionally good, some centers are not so good, but there's a huge and significantly different spread. So if you're a patient, arguably, where you have your radiofrequency ablation is more important than anything else. And so the experience of the center is going to lead to a good outcome or a bad outcome in terms of arrhythmia freedom. Whereas with cryoballoon ablation, it really doesn't matter. And so cryo kind of becomes the great equalizer. And so it's postulated that the reason that the more recent cryo studies were positive for ablation as a first-line experience is because you get a more homogeneous outcome and less variability. Whereas with radiofrequency, you can get bad procedures, you can get good procedures, and it's kind of all over the map. Just lastly, before we wrap up, the question is that, okay, so all of the patients in these studies were paroxysmal, they're relatively healthy, they're relatively low risk. And so do these results apply if patients have persistent AFib or more advanced forms of AFib? And so if you look back at the Cabana data, I think the Cabana data would support that conclusion that it does. So Cabana was a big study of ablation versus drug therapy. It included paroxysmal patients and persistent patients that followed them for many years. The outcome of Cabana was, survival, stroke, those types of things. But if you look at their freedom from AF or AF burden, you see that the burden on the paroxysmal patients is lower than the burden on persistent patients, which makes sense because they're different types of AFib. But you can see that the pattern of separation between ablation in red versus drugs in blue is very similar. So the relative benefit of ablation is no different if applied to a persistent patient versus a paroxysmal patient. So there's no reason to suspect that if you had a patient in front of you and you were going to start your first therapy for AF, that drugs are going to work better for ablation and persistence, but not in paroxysmals. You see the same benefit for both therapies for those groups. So I think it's reasonable to extrapolate the trial results to persistent patients from paroxysmal patients. The other reason I think it's reasonable is that as clinicians, we're really not very good at classifying AFib. So one of the sub-studies we did in Circuitos is we had the clinicians classify patients based on paroxysmal versus persistent using a standardized definition prior to loop recorder implantation. And then we used the 3 months of loop recorder data prior to ablation to reclassify them based on what we observed. And what we showed was an agreement by kappa of 0.2 between the clinician assessment and a loop recorder assessment. And so clinicians were okay at figuring out, percent time in AF or burden based on their classification, but you see much better separation when it's done by device. And this was much better able to predict the clinical outcomes. You can see 3 distinct patterns here in terms of survival from recurrent AF. However, when the clinicians were judging it, they weren't able to make that separation. So clinical judgment's not perfect at determining which type of AFib we're seeing in front of us in the office. And then the last question is the definition even relevant? So our current definition of persistent AFib is continuous AF longer than 7 days. Paroxysmal AFib is less than 7 days. So the 7-day threshold is arbitrary and came about in the mid-90s. It wasn't based on any pathophysiological data. There's arguments that there's pathophysiological data that supports probably a clinically meaningful difference in outcomes at 24 hours. We went back and looked at this in Circuitos. We classified patients' ablation outcomes on the basis of their longest AF episode duration recorded prior to ablation on their loop recorder. And you can see that patients with AF episodes lasting less than 24 hours did very well in that dark blue line, but all the other time periods were the same. So it didn't matter if your AF was persistent longer than 7 days, or if it was paroxysmal 2 to 7 days, or paroxysmal 24 to 48 hours even. because all of those outcomes were very similar in terms of the response to ablation. And so the argument is that maybe our definition of paroxysmal AFib should be 24 hours. And if a patient tells you they're in AFib for longer than 24 hours or not longer than 24 hours, that should be a reliable history to elicit. And so I think that, maybe we need to revisit what we consider to be paroxysmal versus persistent AFib down the road. So if we think about the lessons learned from these two studies we published over the past year or two, I think the key thing is that treating AFib improves patient outcomes and improves clinical outcomes. It seems reasonable to consider ablation as a first-line treatment because it works better than antiarrhythmic drug therapy. We already know that if the antiarrhythmic drugs have failed, ablation is much better at improving symptoms and quality of life. We know that using contact force radiofrequency or cryo, both are very effective at performing pulmonary vein isolation procedures. And we really need to rethink as an electrophysiology community our concepts of AFib in terms of how we classify it and how we judge efficacy for randomized studies or other procedures. So thank you so much for listening. There should be some time for questions, I guess.
Hi, Jason. That was great. I'll request them to let me show my video. Yeah. Okay. So, Jason, that was fantastic, and we were all amazed by the very logical thought processes that guided your clinical trials, and also how you were able to summarize all the results and answer all the nuances that come to mind. I have Dr. Rob Beanlands and Dr. Pete Liu here. I'll take the opportunity to let them first congratulate you while I look at questions coming through. Dr. Beanlands and Dr. Liu.
Jason, thanks for coming, man, all the way to Ottawa. Yeah. I didn't know about your med school. That's cool. Yeah. I won't ask when that was.
2000 to 2004.
Oh, okay. Anyways, you're doing awesome work. Really, really great to see. And I thank you for coming to the rounds today. Is there anybody who you would not refer for ablation?
So I don't think ablation has to be considered as a universal treatment or a treatment for everyone. So I guess the brief answer is there's lots of people who shouldn't have an ablation. I think that where we stand as an EP community is trying to figure out how the results of EAST influence what we do. So, EAST told us that, newly diagnosed AFib should be treated with rhythm control, and that reduced outcomes such as stroke and death, which makes sense, right? If you get rid of the atrial fibrillation with rhythm control, those outcomes should improve. And that's what they saw. The quirk of EAST is that this past ESC, they presented an analysis showing that whether you were symptomatic or asymptomatic, you got the same outcome, which again makes sense. If you're asymptomatic, newly diagnosed AFib, and you're suppressing the AFib with rhythm control, then why wouldn't you see that benefit in terms of reduction in stroke? The problem is that up until recently, we've only ever done AF ablation procedures to improve quality of life. All right, so when you failed a drug and your quality of life was impaired, we do an ablation procedure for you. The idea of performing an invasive procedure to ablate AFib in an asymptomatic patient, I think gives some people discomfort. And so I don't know that we necessarily know where that sits. I think that, conceptually, I looked at EAST as the why we should do rhythm control, and early AF and the other two studies as the how we should do rhythm control. But we're still kind of left with a bit of a disconnect of not knowing, how aggressive should we be for ablating all the newly diagnosed AFib versus not. We also have to consider that, heart failure patients derive mortality benefit from ablation procedures relative to non-heart failure patients. And then we have our standard indication, which is patients who fail drugs. And so within those three pools of populations, you can very quickly overwhelm access to the healthcare system and our ability to actually deliver these therapies. And so I think as a community, we need to come together and figure out how we prioritize these groups and how we can, more effectively treat them. It may be that, technological innovations such as pulse field ablation, I mean, they can do an ablation procedure in less than 30 minutes now in Europe. That may improve the access issue because your first procedures can be much quicker and be done in a way that, reduces the risk of complications. And so maybe that will change the dynamic in the next 5 years. But I think, it's where it sits right now is it just comes down to what are we going to benefit the patient from? And, do they have a lot of comorbidities that would put their risk at an exceptional level that wouldn't warrant it? But I think these studies highlight that, at a minimum, you should consider ablation for most of these procedures for these patients and at least think about it before deciding yay or nay.
Thanks, Jason. I see a couple of questions here. So first, can we unmute Dr. David Burney so that he can ask the question directly? And then I have one from Dr. Ross Davies, so I'll read that out.
I'm hoping you can hear me.
Yep.
Jason, firstly, congratulations for your work. Your body of work is remarkable for somebody so young, or maybe somebody who just looks young. Maybe you're not young, but it's a remarkable body of work. Congratulations. So my question really relates to a group of patients that I really have trouble with, and we all have these patients. They always go to the emergency room for cardioversion because episodes never self-terminate. It's a bit of a self-fulfilling prophecy because they always go to the emergency room for self-termination, for cardioversion. What is your sense on how they respond to ablation? Do you think they respond more like the persistence or more like the paroxysmals, or hard to say?
So I think it's hard to say. I mean, one of the slides that I showed Girish this morning is that if you look at atrial remodeling and the electrophysiologic parameters that change in response to an AF episode, most of the changes are complete within 24 hours. So up to 24 hours, you don't have the adverse effect of the AF episode changing EP parameters such as refractoriness. But once you get beyond 24 hours, it's no different. So whether your episode terminates at 3 days or 7 days, you've already achieved the negative electrical impact on your atrial function by that point. One of the criticisms of the current definitions of paroxysmal versus persistent is that by cardioverting people within the 7 days, you're effectively reclassifying a bunch of persistence as paroxysmal because their episodes never lasted longer than 7 days. And so you contaminate your definition of paroxysmal with a bunch of persistence that had intervention. I mean, my feeling is if you have a patient who's at the point where their episodes are not terminating on their own and that they require intervention to terminate them, then that is highlighting that it's a more advanced substrate and likely someone who's going to have a negative response to ablation relative to people who are able to go in and out of AF on their own. Their atrium has to be healthier if it's stopping on its own relative to those where you require intervention. Those people who have, say a knee-jerk response who present to the emerge 2 hours after their episode starts, it's going to be a mishmash of probably all those groups, so it's hard to know.
Yeah, no, that's my sense too. Yeah, thank you.
Thanks. Dr. Liu has his hand raised, so I'll let him speak and then I'll ask the next question.
Great. Yeah, so just echo everybody's comments in terms of the amazing contributions, from your studies. They are really changing guidelines and very, very well thought out systems of the studies. And so a couple questions. One is that I'm learning, sort of about atrial fibrillation with my friends, Girish, David, and Pablo, and the whole team. And that is that, one concept is that, atrial fibrillation is like a failure of the atrium, since I'm a heart failure person, and that the AF begets AF, and also AF can beget heart failure. And of course, the whole thing is circular. And and the general premise is, sort of earlier intervention. So the question is, in fact, the old concept, in fact, AF begets AF, and AF gets heart failure, is illustrated by this. And then to follow up on the risk, because we probably need to risk stratify to identify best patients who get the maximum benefit. And certainly, the patients with heart failure nowadays do get the mortality benefit, as you mentioned. What about the atrial morphology or other risk factors, that may help us to decide or to kind of differentiate risk of the patient, so that we can prioritize the patients for the procedure.
Yeah, so this becomes a very complicated question very quickly. One paper that we have under review is we've taken about 13 risk prediction scores looking at outcomes of ablation procedures, and we applied them all in a cohort of well-defined outcomes. So basically, people will generate a risk score in a derivation cohort and then validate it and publish it, but you never have a direct comparison of multiple scores in a single cohort. And in doing that, I can tell you very clearly that none of the scores tell you anything. They're below the clinical utility threshold. Your AUCs are under 0.6, and these scores include multiple parameters. So some of the scores have left atrial volumes, they include age, they include comorbidities, they include other parameters. And so the problem is that we know that a big dilated atrium is going to have a bad outcome compared to a normal atrium. But there's no threshold that says with absolute terms that this outcome is going to be useless and this outcome is going to be perfect. And then the second part of that is that the outcomes that we're looking at are probably poor surrogates and looking at 30 seconds of AF as a recurrence. And so if I have a big dilated atrium and I can reduce that AF burden by 99%, maybe that's enough for them, even if they have a definition of recurrence. We know from Castle data that VF incidence was reduced with ablation and not drugs. And so these patients had ICDs, and maybe that's the reason that the mortality benefit is there, is because the ablation reduced the likelihood of, them having a malignant ventricular arrhythmia. And so, it's very hard to say. There's MRI data, DCAF2 was just presented that showed if you have high burdens of atrial scar, your outcomes are not great if you have an ablation, and suggests that if you start ablating all over to get rid of that scar, they actually increase the risk of stroke. So maybe there's complications for doing more during the ablation procedure. So, I think, as I said earlier, as an EP community, we're going to have to somehow come together to figure out what the safest, most effective procedure we have is, and how we apply that to the largest population will derive the most benefit.
Yeah, thanks, Jason. And I have two quick questions before we wind up. One is from the chair of our REB, and one is from the head of head of heart failure here. So the first one is from Dr. James Robley, which says he thanks you for an excellent presentation. And as the head of the Research Ethics Board, he wants to know, is it ethical to undertake an ablation study without using an implantable loop recorder? And the other question was, what is the duration of AF on a device that you would recommend for starting oral anticoagulation therapy, which is not related to this talk, but as the co-chair of CCS AF guidelines, I think you can answer that too after the first one. Thanks.
Sure. So with respect to the ethics question, I think it is ethical. I'm just pulling up a different slide because I'll show you why. Okay, so this is an analysis just basically looking at how the outcomes would be seen after monitoring. So this one, I actually showed you in the presentation, a different version of it to highlight the differences between the studies. And so you can go through all the different ways you would monitor and see how the outcomes look. This is the one that I wanted to show that was a bit more important. So what we did in this analysis, which has just been accepted in circulation, but I don't think it's available online yet, is we looked at different non-invasive monitoring methods and compared that to the loop recorder in terms of burden of atrial fibrillation. So this is trying to use a non-invasive method to determine how much AFib someone is actually experiencing. So it's been argued that you cannot determine atrial fibrillation burden except if you have an invasive monitor. What we showed in this analysis is that using 3 14-day Holter monitors over a year gives you about a 90% correlation or agreement with the invasively derived burden. And so if you're undertaking a study and you want your outcome to be burden, it's reasonable to use 3 14-day monitors, recognizing that it's only got a 90% correlation to the invasive burden assessment. And so we did this analysis in patients who had a zero burden and a non-zero burden or only, and we saw very similar results. So I think that from this paper, one of the key messages will be, if you aren't using a loop recorder, a 24-hour monitor, which is this bottom left dot, 1-day ambulatory ECG times 3. I mean, that's only a 50% correlation with burden. So it's just completely useless. 48 hours is mostly useless. 7 days is not bad at 85%, but really the 14 days is where you have to go if you're trying to non-invasively quantify burden. If you want to take a step back and really talk about the utility of the different monitoring, I mean, this gets into a very nuanced discussion, but the idea is that the less time you look with your monitor, so if you use a 24-hour monitor versus a 14-day monitor, you're going to miss a whole lot of recurrences, right? So there's a 40% difference in terms of absolute detection of recurrences, but the recurrences that you found are much more meaningful. Right? So the AF burden of the recurrence I detected with a 24-hour monitor was 1%, but the AF burden of the 40% of recurrences I missed was 0.09%. So because, AF can happen at any time over the year, if I only look for 3 days out of 365, and I happen to hit on AF as a binary recurrence, then over those 365 days, that person has had a whole lot of AF. Whereas if I look for 14 days 3 times, so now I have 28 days of monitoring, and I happen to hit on AF, that burden is lower, and that which I missed is much lower. So, this is another level conversation around, do we even need to have loop recorders? Because all the recurrences I'm finding might just be completely meaningless, because it's just 30 seconds of AF detected on a loop recorder. Whereas if I don't look very much and I still find it, those are maybe the clinically important recurrences. And so that actually kind of dovetails into the second question, which is, if I have a pacemaker patient and they have some AF on their pacemaker, I see it because I'm recording everything. So at what point does it become meaningful? Based on Jeff Healy's ASSERT analysis, which was redone by Isabel Van Gelder, it's probably 24 hours of continuous AF on a pacemaker is clinically meaningful, and you should treat that like clinical AFib. Under 24 hours, we don't know, and that's sort of the subject of the Artesia study, which is looking to determine whether anticoagulating that group has benefit. And so for us, we've been enrolling under 24 hours, and we've been anticoagulating over 24 hours.
Thanks, Jason. That was fantastic. And so on behalf of the University of Ottawa Heart Institute Cardiology Division, Research Services, and the Arrhythmia Group, the residents, would like to thank you for dedicating a whole day to us. And we know that you have another session for the next hour with our young faculty and fellows. So we're looking forward to that. And hopefully we can have you here in person one day in the near future.